If you could pull out your handout for head and neck space infections, and let's review first what's on the handout, then we'll go through the slides. The handout material includes some cases right at the beginning that might actually commonly present to anybody from a primary care doctor to a subspecialist. But many of these common illnesses can have very uncommon but life-threatening complications, which is what the main focus of this lecture is going to be. This is about how infection can track through the various spaces of the head and neck. And the routes are almost predictable and are very important to understand. So we'll talk about each of these, focusing on first infections in the head area and where they track to, and including other parts of the body. Then we'll look at some of the other infectious syndromes like sinusitis, lateral neck space processes, the anterior neck, ear syndromes. All of these are on page 3 of your handout. And run through those so you understand clearly what the differential diagnosis of these processes or masses or presentations can be. With that, let's begin. Our first slide begins with a case of a 25-year-old man who presents to the emergency room with a sore throat, an incredibly common presentation. He had been previously well. His temperature is 103 degrees. He has a mild headache. The rest of the examination is unremarkable, except for pharyngeal erythema and a slight exudate on the left peritonsillar surface. A rapid strep test is negative, and he's discharged without antibiotic treatment and told to take fluids and Tylenol. This case is probably repeated over and over in both emergency rooms and doctors' offices all over the country. And once strep is at least quickly ruled out, or for the most part ruled out, patients are sent home and told they might have a virus or some other simple process. However, 2 days later, this patient returns. And this time he has a higher fever to 102 degrees Fahrenheit, and he's short of breath. And this suddenly isn't so common. There is no change in the exam of the pharynx, so he still has some pus there, but not much. And the chest x-ray shows 2 cavities. So he has 2 cavitary lesions. A CT examination is then done of the chest, which shows 3 additional lesions. So he now has 5 cavitary lesions in the lungs. He's short of breath. He is very, very sick. What's the most likely explanation for these findings? Is this strep pneumo, a pneumococcal pneumonia? Is it right-sided endocarditis? Does he have a septic venous occlusion, melioidosis, or tuberculosis? Well, the latter 2 certainly can cause cavities in the lung, but this is a very acute presentation and seem quite atypical for that. Pneumococcal disease rarely causes cavitary disease, and the pharyngitis presentation is also unusual. A right-sided endocarditis is possible. Presenting with pharyngitis is unusual, and we're not given any risk factors for right-sided endocarditis. We don't have any other skin lesions. There's no history of drug abuse. But it would have to be in the differential diagnosis because it would explain something flipping septic emboli to the lungs and causing cavities. But the real concern in this man should be a septic venous occlusion. And that's in fact what he had. This patient, though, then develops purulent pericarditis. He has pus around the heart. And the question is, why did that occur? Is this bacteremic spread to the pericardium? Is it a rupture of a valvular abscess? Does he have direct extension from a cavitary lesion? Is it tracking from the peritonsillar space posteriorly, or none of the above? Well, you might say, it could theoretically be any of them, but let's run through these. It could be a bacteremic spread to the pericardium. He certainly is sick enough that you would expect he might have bacteremia, and if he's bacteremic, those organisms can go anywhere and could seed the pericardium and cause purulent pericarditis. He's got 5 cavitary lesions. We're not told where, so maybe one of them abuts up against the pericardial surface, but we're also not given air fluid levels in these cavities or any other evidence of pus in the cavities, but still, one of these might be a source of infection for the pericardium. A direct extension from a cavitary lesion is therefore possible, just as he might still have right-sided endocarditis and ruptured a valve. But the most likely thing that would connect everything together, starting with the pus in the throat, down to the cavities in the lung, and the pus around the heart, would be number 4, tracking from the peritonsillar space posteriorly. Let's go back and see how this could have happened and what are some of the processes that really explain the kind of life-threatening infections that we need to cover today. Let's start with peritonsillar abscess, which is what this gentleman had and started with probably. A peritonsillar abscess can present with pus in the peritonsillar space. It is usually less fulminant than Ludwig's angina, and local pain and dysphagia are present. Typically, the organisms include anaerobes, Eikenella, group A strep, and even diphtheria. If that peritonsillar abscess extends into the lateral neck, so it's starting in the peritonsillar pillar with some pus, occasionally it can go deeper into the lateral neck structures, then get to the jugular vein and cause a jugular vein thrombosis, which really is what our initial case suffered from. That can then flip emboli to the lung, and these are septic emboli which frequently can cavitate. However, if that's syndrome 1, what can also happen is you still have pus in the lateral neck that can track posteriorly and goes to the posterior spaces, which eventually you can reach a space that has no valves whatsoever, goes right into the medial mediastinum, drops into that area right in the pericardial sac, and can cause both a mediastinitis and a purulent pericarditis. Each of these emergencies starting in the oral cavity are characterized by local pain, dysphonia, dysphagia, trismus, and inspiratory stridor. All of these are on that first page of your handout. And so when a patient presents with any of these things, these are the things to worry about, these kind of differential. Let's go through some more of these. The first on the bottom of your handout on this slide is Ludwig's angina. Ludwig's angina is an infection of the sublingual and submandibular spaces. So this is the area right under the tongue. Risk factors are poor dental hygiene or sometimes recent dental work, but up to half the patients who have Ludwig's angina have no history like that. They can just present with a swelling of the sublingual or submandibular spaces. The swelling forces the tongue to the back of the throat, so most of the tongue is pushed posteriorly. The tip of the tongue may be sticking out of the mouth. So the mouth is really often open wide. It doesn't look like it because the tongue is so swollen, with the tip sticking out and the rest posteriorly pressing backward and occasionally obstructing the airway. The organisms are what's found in the mouth, so it's a mixture. Gram-positives and anaerobes are typically present. As you think of patients with Ludwig's angina, there isn't that much to drain. So this is not usually a pussy disease. This is an edematous swelling illness, but not very pussy. The main thing for Ludwig's angina is to first make the diagnosis, then control the airway, and make sure that the person is safe as far as breathing, and then initiate antibiotics directed against that oral flora. And typically most patients will improve fairly rapidly. So as opposed to our first case of the lateral neck infection, which had a little bit of pus that began to track, Ludwig's angina typically is not very pussy, but still has local obstruction as the main problem. Now let's move around from the base of the tongue to the lateral neck to the retropharyngeal area, and here the problem is a retropharyngeal abscess. A retropharyngeal abscess, unlike a lateral neck abscess, is more difficult to see because it is sticking out kind of at the examiner. It's coming out at you. So it sometimes can be missed on a direct examination. Patients can develop trismus, which can be due to spasm of the pterygoid muscle, so they can have trouble masticating or even opening their mouth. And this is a process that is more pussy. So we go from Ludwig's, not much pus at all, lateral neck, some pus, to retropharyngeal abscess, which is much more purulent. In fact, purulent enough that it can just spontaneously pop and drain into the airway. And in fact, that drainage itself can cause asphyxia. And it's been called a malignant phlegmon, or the spontaneous drainage being actually fatal to individuals. Just as the lateral neck space can extend into the jugular sheath and clot the jugular vein, causing all the complications we talked about in the first case, the retropharyngeal abscess can extend posteriorly into the posterior spaces. And although the first posterior space really ends at around C6, the one right behind it, and there's a series of potential spaces, is this same valveless space that the lateral neck infection can track to. And in this case, the retropharyngeal abscess is quite near this space, and if instead of draining into the airway, it drains posteriorly into that space Once again, the patient develops pus in the mediastinum and can develop pericarditis. Further posterior penetration can lead to central nervous system infection. So again, Ludwig's lateral neck and retropharyngeal space can be differentiated by the kind of purulence and what needs to be drained, so that retropharyngeal abscess needs a drainage procedure as a very early treatment. But the knowledge of the spaces, and actually in my opinion the names of the spaces are much less important than the concept, that tracking to the lateral neck rarely involves the arterial side, but if it did, one can get infection into the brain. Much more commonly involves the venous side and the jugular vein, leading to clot, septic clot, and embolic formation to the lung, and then further tracking posteriorly with all of these spaces potentially connecting as the infection is spreading. What this means to the practitioner is when the patient presents with purulent pericarditis as the starting diagnosis and a history of a sore throat, looking northward into the head and neck space and understanding the spaces directs your diagnostic studies. So it would not be sufficient to merely drain the pericardial sac and find Eikenella there and think you're done. When you drain the pericardial sac and find an organism like that, you need to look into the head and neck area and make sure you've got it all. And similarly, if somebody has septic thrombosis, treating the bug in the blood and monitoring the lungs does not stop the process from going on. So one has to evaluate the head and neck spaces, typically with CT or MRI, and make sure you understand the extent of the infection and the routes of tracking. Unlike, for example, compartments in the leg, in the head and neck space, there is very easy tracking of infection from space to space. These routes are predictable. Again, the lateral neck to the jugular vein with carotid involvement rare, then posterior tracking to the danger space and extension to the mediastinum, and all of this requires not only good visualization, but good surgical support. Let's go over some of the ear syndromes patients can get. One of those would be an adult with otitis media. Otitis media can be seen in children, but is actually very uncommon in adults. You can see it in influenza season, occasionally in swimmers, although external otitis is more common in swimmers. For that patient who is an adult who gets recurrent otitis media, even when it's responsive to antibiotic therapy, I would consider a nasopharyngeal obstructing lesion and get a good nasopharyngeal examination looking for malignancy. Malignant external otitis is a syndrome essentially confined to the diabetic. This is typically an invasive bacterial process, usually associated with Pseudomonas aeruginosa as the pathogen. And these are patients that are not particularly febrile. They don't really have much in the way of systemic symptoms, but they have a progressive destruction of local tissue due to a bacterial infection in an area compromised by small vessel disease, usually due to diabetes. These patients almost act as if they've got a basal cell carcinoma, and typically the disease process is progressive despite antibiotics or wide debridement. Patients with painless otorrhea, that is discharge from the ear without any pain or anything else, should be evaluated for the possibility of TB if that discharge is chronic. And tuberculosis in the ear or in the sinus or the mastoid air cells is an important part of the differential of this syndrome, and it's important not to miss it. If you look on page 2 of your handout, there's a discussion of parotitis, which is the swelling of the salivary glands. What's presented there is a 32-year-old woman who has a 4-week history of fever. And at first she has significant fever for the first few weeks. Then she develops some bilateral facial swelling in the area of the angle of the jaw. She has local pain, has trouble ingesting food, and some trouble phonating. And going through her differential, the question is this mumps? What are the other parts of the symptoms? And what is bacterial peritonitis, or parotitis rather? Parotitis, certainly mumps can occur unilaterally or bilaterally. But when people have a lot of pain, particularly when there's a question of pain with ingestion of certain types of fruits like lemon or other things like that, they may have obstruction of the parotid glands, and certain stones can cause obstruction there, and it may be associated with syndromes like Sjogren's syndrome. Another thing to consider would be uveoparotid fever in patients with this, and a consideration of sarcoidosis or other syndromes would be part of her differential diagnosis. In closing, as you think of the head and neck space infections, most of these are common disease syndromes: otitis media, external otitis, sinusitis, pharyngitis, dental space infections. that we see all the time and that primary care doctors see all the time. The thing that you need to be particularly aware of, though, are the complications of these diseases. For patients who present with any one of those common illnesses, but if you add on difficulty phonating, drooling, trouble handling secretions, or unusual distant complications, cavities in the lung, purulent pericarditis, and the like, almost certainly we're moving into an area where you have a neck space infection that is tracking. Understanding those routes of tracking is critical. Lateral neck to the lateral sheath and jugular vein and carotid, posteriorly to the danger space going into the middle mediastinum, are predictable once the pus gets in those areas. So it's control of airspace for Ludwig's, it's drainage of the lateral or posterior neck when you find it, of course it's appropriate antibiotic therapy, and it's predicting the next site of infection and making sure the patient is in a setting where they can best be taken care of.